my name is Dr. Michael Wallace. I'm a professor of medicine at the Mayo Clinic in Jacksonville, Florida. I'd also like to introduce my colleague, Dr. Maryam Alahmad.
Hello, my name is Maryam Ahmed. I'm one of the gastroenterologists at Sheikh Shakhbout Medical City from Abu Dhabi, United Arab Emirates.
And it's our pleasure today to present an overview of this topic, artificial intelligence for endoscopy, and particularly some of the data we've recently gathered from Sheikh Shakhbout Medical City. So let's go ahead and begin. These are our disclosures here, and I'll just move our pictures over to the side a little bit. These are our disclosures. But I'll go ahead and start for the first 5 minutes, then Maryam will continue, and I'll pick up again at the end. So today we're going to talk about some of the types of AI and GI applications, but particularly focus on computer-aided detection, where most of the literature is coming from these days. Computer-aided detection refers to the ability of computer technologies, particularly machine learning, and more broadly AI systems, to detect and classify lesions that we see on a computer screen or on an endoscopy screen. And the most obvious application that likely many of you have heard about is endoscopic lesion detection, such as polyps. They've also been shown to be very effective at detecting colitis, Barrett's esophagus. It can also be used to detect and classify other relevant images from the radiographical field, such as pancreatic tumors or cysts, or anything that we look at on a CT or MRI. And one of the most practically beneficial applications are things like auto report generation. Because it can see what we do and generate text, it can actually start writing reports just based on what's on the visual screen. And it can certainly automate common tasks that we do, such as measuring bowel prep scores, withdrawal time, even adenoma detection. We won't have time today to talk about generative AI or other systems, so-called ambient clinical intelligence, but these are certainly applications in the GI space. So currently, there are multiple systems in use in the endoscopy space. The three that are currently approved, at least in the US, and some of them are also available in the United Arab Emirates, the Cosmos system, now licensed to Medtronic, the Fujifilm, so-called CAD-I system, and the Scout system is available in the US, and I don't believe it's available in the United Arab Emirates. But we have our greatest degree of experience with the Medtronic, so-called Cosmo or GI Genius system. And we'll talk a bit about the data for that today. And we can also show some of the images from some of the other systems here. So this is a video recording of one of the systems. This happens to be the GI Genius system, and it shows how these systems work. It's real time. As you're doing your pullback during colonoscopy, it puts a so-called bounding box, in this case, a green box around this polyp. I chose this video because it was a somewhat difficult polyp to see otherwise. We're currently in narrowband imaging mode, but you can use white light mode or other blue light modes. And it detected this polyp and flagged it. And this is a polyp. Some people would agree we could certainly miss such a lesion. Some of the polyps are very obvious and don't necessarily need any supplemental systems. And that's true whether you're just using NBI or blue light or an AI system. But some of the polyps are hard to see. And we'll show some of the data that this technology may improve our ability to detect polyps that we otherwise wouldn't see, or alternatively avoid missing polyps that we might otherwise miss. So this particular technology is one of the best studied. The so-called GI Genius technology was the first system available. And because the US Food and Drug Administration and also the European Commission required quite rigorous studies, typically 2 large randomized controlled trials, that was the criteria for getting this system approved. So this was the first of these large randomized controlled trials. These were data collected predominantly in the US and Europe, and it showed that there was an overall significant increase in the adenoma detection rate from a baseline, which was already fairly high of 41%, up to a even higher level of almost 57%. And that increment was positive across all sizes, although statistically it was only significant for the smallest polyps, but the study was not powered to detect differences in different size polyps. It happened to be significant for both so-called polypoid, your pedunculated 1P polyps, as well as your flat polyps, or so-called non-polypoid. And I'll just move the image over here so we can see on the right. It also was true for polyps in the proximal colon as well as the distal colon. This was followed by a second trial that I was involved with, which was a so-called random tandem trial. Tandem meaning both patients, or each patient got both procedures. This is a very powerful study design. You can see it didn't require as many patients to achieve significance. But 249 patients were randomized to 2 colonoscopies, and only the order was changed. So either they got a standard colonoscopy first or an AI colonoscopy first. And in this case, all the polyps were removed when they were found. So when they got that second procedure, the only polyps that remained were polyps that were missed on the first procedure. And so the primary outcome of this study was actually the miss rate of polyps, which was equivalent to the number of polyps found on the second procedure. And this is a graph. Again, I'll just slide our picture over to the other side. You can see that the overall miss rate had decreased by about 52%, including all polyps. And that was there was a lower miss rate for every single range of polyps, whether it was diminutive, small, larger polyps, although statistically it wasn't significant for the largest polyps. It was also statistically most significant for the so-called non-polypoid, your sessile and flat polyp. And as in the previous study, it was true for both proximal and distal polyps. It was true for various indications such as screening, early or late surveillance. We actually excluded patients who did not have adequate preparation. So it was obviously positive in those that did have adequate preparation. Now, these 2 trials led to the worldwide approval of this technology, both in Europe, the US, and including the hospital where Dr. Maryam Alahmad and I worked together in Sheikh Shakbud Medical City. And we implemented this system in our practice. But soon after we implemented it, a couple of studies came out that suggested maybe it doesn't work as well in practical or post-implementation. And this was perhaps the most publicized of these. This was a study out of Stanford University. Dr. Yuri Ladabaum, a very highly skilled investigator and colonoscopist, showed that their adenoma detection rate and their adenomas per colonoscopy, if they measured those before they implemented this technology compared to afterwards, there was no difference. They speculated, well, maybe it's just those that have the lowest adenoma detection rate that are benefiting, but it didn't benefit those that already are at very high levels. And so they tried to study that and didn't actually see that either. These are the lowest third or lowest tertile for adenoma detection rate, middle third, upper third, and they really didn't see much of a difference across the range of endoscopists. Although if you look numerically in the lowest third, you generally did see a slight increase in most of those users between pre and post implementation. And similarly, a bit of a scatter for post implementation, but those that really had the very highest adenoma detection rate clearly didn't get much higher with the technology. So that raised some doubt, and it was, I think, very important question is, does this work as well in practice as in the clinical trial? So I'm going to turn this over to Dr. Alahmad now to present a very similar study that we did together in Abu Dhabi. Maryam, go ahead and take it away.
Thank you, Dr. Wallace. I'm going to present our results from the study which was conducted at Sheikh Shakbut Medical City. It's a case-controlled study, retrospective, showing the real-world evidence in young screening population age. Can you move on to the next slide? So in our study, we aim to explore the efficiency of AI-enhanced colonoscopy within a clinical setting in the Arab region with a high incidence of early onset colorectal cancer and national screening program with a low screening age of 40 years. It's a single center conducted at Sheikh Shakbut Medical City in Abu Dhabi, retrospective case-controlled study. From September 2021, directly after implementation of AI in our clinical practice. So our inclusion criteria were patients of age 18 up to 89 years old, all patients who were scheduled for routine outpatient colonoscopy for screening, surveillance, or diagnostic indication. Our exclusion criteria were inadequate bowel preparation defined by Boston Bowel Prep less than 6 and incomplete procedure. So at the SSMC endoscopy unit, AI GI Genius was implemented in one of 4 rooms. Assignment to AI versus non-AI rooms were pseudo-random based on schedule and space factors. AI colonoscopy were matched to non-AI colonoscopy in 1:4 ratio with control based on endoscopist, gender, and indication. All patients were consented for the procedure and notified of the use of AI. The primary outcome were APC and ADR comparing colonoscopy with and without AI. Secondary outcomes included polyp detection rate, number of polyps per colonoscopy. Tertiary outcomes were APC-PPC ratio, histology size, and morphology breakdown of the detected polyps. So among the 840 patients in our case control registry study, 72 were excluded who had inadequate bowel preparation, and our final analysis included a total of 768 patients. 161 with AI were matched with 607 without AI. So both groups were well balanced. For example, median age was identical of 48 years. In addition to age, both groups were overall well balanced to multiple factors such as race. With regards to primary outcomes, APC, we observed almost doubling results, 0.29 in the group without AI compared to 0.60 in the AI group. This difference was highly statistically significant. Similarly, ADR was significantly higher in AI compared to non-AI group. Polyps up to 5 millimeter were detected in significantly higher proportion in colonoscopy with the AI group. So our study supports the evidence from the previously conducted randomized control trial in USA and Europe by also finding that AI do improve the ADR and APC. It suggests that the results seen in clinical trials can be generalized to an outpatient clinical practice setting in the Middle East. However, it should be mentioned that there is conflicting evidence from other studies done in a practical setting in USA where the implementation of the technology did not show improvement in the ADR, neither the APC. The strength of our study are the young age of screened population, along with the highly diversified ethnicities in our population. Based on our study results, we conclude that the use of AI-assisted colonoscopy improves of the quality of colonoscopy as measured by ADR and APC in a clinical practice, low screening age population in the MENA region.
I want to turn back now to some of the other evidence where AI may be applied to both colonoscopy as well as other non-colonoscopy applications. So we've talked about a fairly sophisticated application, adenoma detection, which is at the core of ensuring high-quality colonoscopy. But there are other, maybe less sophisticated applications, but are nonetheless practically very important. So we all know that we have to score the bowel preparation. And whether it's considered adequate or inadequate determines whether that patient can follow a normal surveillance interval or has to have the procedure repeated. So important implications. We also know there's variability in how endoscopists report the preparation, whether it's a Boston Bowel Prep 1, 2, 3, or 4, or whether you just dichotomize those. Adequate is currently defined as a Boston Bowel Prep 2 or 3, whereas inadequate is defined as a Boston Bowel Prep 0 or 1. So with my colleague, Dr. Ji-Young Lee, we published this study about 2 years ago now, looking at whether we could classify bowel preparation. We actually compared this to the people who developed and really validated the Boston Bowel Prep score, Dr. Audrey Calderwood and Dr. Brian Jacobson from Boston Medical Center, hence the name Boston Bowel Preparation. And what we were able to show here on the left-hand side is the area under the receiver operating characteristic curve, which is the general measure of accuracy. And you can see that the AI tool was extremely accurate, defined here as an AUC of 0.918, perfect being 1.0. On the right, you can see the graph of how the endoscopist scored individual cases. So patient number 1, patient number 2, patient number 3 across the top, and the right transverse and left. And we dichotomize the outcome as either adequate or inadequate. And you can see 4 different endoscopists, including 2 from the Boston team and 2 from our Mayo Clinic team, scored these. And there is clearly some variability whether the human expert readers, how they scored these. The gold standard, by the way, were consensus cases where all 4 endoscopists agreed that it was either adequate or not adequate. That's how the system was trained. But you can see that human expert readers actually had a modest, fairly modest to good agreement, a kappa of 69 to 89, or agreement 69 to 89% with a kappa of 0.6996 to 649. Now, what's next for endoscopy? We've seen not only bowel preparation, we've seen Barrett's detection and classification, we've seen gastritis, early gastric cancer, we've seen colitis scoring systems. But what's happening now is much like what we've seen in other technologies that are converting to a so-called platform-based system. What platform means is that instead of having one application, much like your smartphone isn't just a phone, it's got multiple other applications. The key feature of platforms is that you have a single technology where other third parties can put their classifier. You can take what's the published literature of a Barrett's detector and classifier, a gastric dysplasia detector, a colitis classifier, and put these all on the same platform, much like you have multiple apps on your smartphone. This will allow the more rapid expansion of these tools. Instead of buying one device for one application, we buy one device for multiple. In fact, can be hundreds of applications in our endoscopy suite. Before we finish up, I want to talk about some other very obvious applications, not directly in the flexible endoscopic space, but in the capsule endoscopy. This is where it may turn out to be a huge time saver. We all are aware of how much video we get on these capsules, up to 8 hours of video, with often only 10 to 20 seconds of relevant information. But we have to watch those, and various hospitals allocate 60, 90, perhaps even 120 minutes of time for physicians to read these, much of which is not very useful time. This was a really nice study showing that these systems can be trained to filter out just the relevant videos. This was a study out of China, a very large study, 5,000 patients. In this case, the standard was 20 experts reading the capsules and classifying the lesions, and they reached consensus on most of them. And then they trained the algorithm to detect what those 20 experts were detecting. And here's the data. The overall detection accuracy was extremely high for the so-called CNN, that's convolutional neural network or AI-based auxiliary reading, versus conventional reading by a panel of experts. You can see across the whole spectrum of things that we read on capsules, inflammation, ulcers, polyps, bleeding, and parasites. It was able to detect all of these equal to or better than a group of experts. But what was really most remarkable was the time savings. But obviously filtered down, more than 20,000 images on the raw capsule reading down to a very small number of relevant images, less than 100. And most importantly, it reduced the reading time from an average of 97 minutes for an endoscopist to 5.9, again, without reducing any accuracy. So one of the other ways we might apply these is to change our workflow in endoscopy. If you take our workflow, for example, you do a screening colonoscopy, maybe you find a polyp on the left side here, you remove that polyp, but you can't tell the patient what's the pathology and what's the follow-up interval for your next endoscopy, not knowing if it's hyperplastic, adenoma with high-grade dysplasia. So then you have to schedule a follow-up with that patient by telephone or an in-person visit. You then have to go back to your scheduling system and put in a tickler message to remind you to repeat that colonoscopy in 3, 5, 7, or 10 years. And you have to update your electronic health record and perhaps update your adenoma detection rate if you're monitoring that. What if, however, we use these automated workflows with AI, where you do the colonoscopy, it detects that you found a polyp, it can detect the size of the polyp, it can predict with a high level of accuracy the histology of the polyp, and then it can use the existing literature to tell you what's the appropriate surveillance interval for that individual patient, all all at the point of care. So that eliminates this complex workflow, phone calls, visits, interaction with the pathology department, et cetera, where we may be able to make our workflow much, much more efficient. So to summarize, on behalf of both myself and Dr. Alahmad, AI is very rapidly transforming medicine, and GI is really leading this effort with now multiple FDA and CE cleared applications. Computer vision for polyp detection and classification is now in practice, and we've seen other applications for improved efficiency for capsule reading. I didn't have a chance today to talk about some of the other work on pancreas cancer screening and detection, but this looks very promising. And we're very quickly moving towards so-called platform-based systems to allow for multiple application integration, such as an app store. And we didn't talk today about ambient AI, but ambient AI are systems, for example, that listen to an interview between a patient and a doctor and transform that into a clinical note, perhaps some orders, a billing code, et cetera. These really will transform how we gather, process, and document medical interactions, hopefully reducing some of the burden of work and hopefully for the better. But I think we as physicians and other care providers continue to need to guide that process to ensure that these systems really are used for the better and not for the worse. I want to thank you both. Thank you all for participating in our meeting today. Maryam, would you like to add any additional comments?
Thank you so much for the invitation. It was an honor. Thank you, Dr. Wallace.
Thank you all for your kind attention today.